So this question with monitor is an interesting one because they've tended to take the view that any diminution of choice, of patient choice, is a ipso facto a bad thing. However much patient benefit you can demonstrate. James, where have we got? Dennis? Come on, folks, you're going to need quicker than this. That's, do you want to go and assume the position there? So, what, Dennis? Yes. I'm looking for Santiago, who'll come and join us shortly. OK, so let's move straight on. You're going to do a 15-minute tour of the world evidence.
Yes, well,
so,
sort of.
Good luck. Thank
Good
you.
luck.
James Barlow
Indeed,
from Imperial.
Should I kick off and just wait for Santiago? Or, yeah. Right, thanks, Nigel. Yes, no, I foolishly failed to give a title when I agreed to give this talk, and discovered I'd been given a title which was a world tour of the evidence, and I've actually changed it slightly so that it's a world tour of the evidence focusing on some countries and some evidence. So I will explain why it's difficult to do a world tour of the evidence in a second. But what I want to do really is to pick up some of the points that have been made in the previous speakers, and I think this session, next session, flows nicely from that, because I'm going to be talking about some of the boring stuff that actually was mentioned, but sort of slightly brushed aside. To Tony, wherever you are, the contract, and the money stuff, the sort of commissioning and incentivization. So that's what I'm going to focus on when it comes to evidence. But why is evidence difficult? Until Tony's almost penultimate slide, when there was a definition of integrated care, I thought we were going to have 5 speakers this morning who didn't actually define it. I'm not going to try and define it either, but the point is that integration and integrated care and coordinated care is one of these immensely woolly concepts. We think it's a good idea, and we sort of know it's good, and it's needed given the way health and social care demands are progressing. But it's an emerging concept, and nobody really has pinned down what it means. It hasn't been pinned down in terms of its objectives, or really in terms of its essential components. It means different things to different people in different contexts. And really, this goes to the heart of the evidence question. It is therefore very, very difficult to work out what works, why it works, and under what circumstances. And I was just thinking about this just now before I came up on stage. I mean, it's not unlike telehealth, telecare was 5-10 years ago, where there was a lot of talk, something like 9,000 published studies of telehealth, but actually they told us very little because it was just not carefully defined. So evidence is a problem, and I'm going to go on to say what we know is actually very little, and it's essentially a black box if we try and understand what's going on in terms of some of these schemes. There are different ways of understanding integrated care. There's one, quite a widely known, widely reported piece of work by Chris Ham and others, and that's basically looking at the scale and scope of integrated care. Is it focused at populations as a whole? And we'll hear a bit about the Alzira, La Ribiera example in a moment. Is it focused on particular groups of a population, people with particular diseases, particular conditions, for example? Is it focused on the individual, and it's about bringing an integrated package of services to that individual? So, that's one way of doing it, and that's quite useful. But there are many others, and if you look at the literature, there's a whole range of different variations which bring together, all healthcare and all social care, primary and secondary care, even including things like clinical services, support services, and the assets and infrastructure. So there are many, many different ways of cutting the cake. And really this makes it very, very difficult to actually say anything meaningful about what works. However, having done a very, very quick trawl through as much of the literature as I could get hold of last week, there is a very common thread running through a lot of this. And I think that this is really about incentivization and payment models and how we drive change by changing commissioning structures, how we drive change by putting in place appropriate mechanisms for sharing risk and reward. And in all the schemes that I looked at, there was some attempt to do that, and some, depending on what, which scheme you're looking at, to a varying degree of sophistication, some sort of incentivization structure. So that's really what I want to pick out today and talk about in the next few minutes. And really this is all about influencing what goes on. It's about influencing the way organizations work together. It's about influencing the processes by which integrated care, in inverted commas, is delivered. And it's about delivering certain outcomes. And there's a whole variety of different incentivization models that are put in place, but they're essentially all about driving change and delivering a set of performance outcomes. And the vast majority of them are focused on healthcare providers, so the organizations that are actually delivering care services on the ground. But you do find models that are also focused on the payer, the insurer, or commissioners perhaps in this UK specific language, or on patients themselves. And again, you can cut the cake in a number of different ways, but this is one way of doing it. So down one side, we've got the focus of incentives. Is it the provider? Is it the purchaser? Is it the patient? And on the other axis, we've got how healthcare is paid for, how providers are remunerated. Is the system essentially unaltered? So you've imposed or brought in some sort of incentivization model on top of the existing tariff structure or payment and reimbursement system, or have you tried to fundamentally change that as well? And there are a number of examples from around the world which you can slot into this. And I won't talk about all those, but I'm just going to pick out a few of them. And I'm not actually going to talk about the purchaser incentive models and where you'd be perhaps an insurer would be incentivized through some sort of funding allocation formula to target particular groups of people with long-term chronic conditions, for example. They exist, but that's another world. And again, the patient-level incentives, which are part of this story about integrated care. So I'm talking here about changing people's behavior in various ways. Again, and the whole world of personal health budgets. Again, that's a big area, and I don't think it's quite right for today. So what I really want to do is just to focus on the top of that diagram there, looking at providers and how incentive schemes work for providers to deliver integrated care. And this is really about pay for performance. It's about putting in place mechanisms to improve performance and meet certain targets through the payment system. An example that is increasingly talked about, there have been a number of articles about Gesundes Künzigtal in Germany in the last couple of years, which is a good example. And the key bullet points to look at there, the bottom ones really. It's the providers within that scheme are provided with extra payments to deliver services outside the normal range of healthcare services, which are targeted at particular groups of people and which are deemed to be important for delivering better quality care. There's a profit-sharing model in place so that if those providers meet particular levels of performance, then they share in the profits in some sort of formula, according to some sort of formula. And the last point is very important about cherry picking, and that's about avoiding just picking the healthiest or the easiest patients, actually being incentivized to target the most difficult ones and focus on those. So that particular example is, as I say, exists. It's been around for a number of years. It's been written about now to some extent. What is it delivering? Well, certainly the headline figures look good. Reductions in morbidity and mortality rates, support for people who are at risk of falls and so on, better survival rates for heart patients, and at the system level, certainly important efficiency gains in terms of hospitalisation and nursing home avoidance and so on. So it certainly seems to be making some difference. Another example are the family health teams in Ontario, which were set up a few years ago. It's slightly different. These are GP, physician-focused teams. And this is really about incentivizing GPs to work together in groups and collaborate with other specialists. And again, to deliver particular objectives around managing people with certain long-term conditions. It's a much more complex model. There are a number of different funding routes through which GPs are remunerated, or these GP groups are remunerated. There are additional incentives for putting in place electronic health records and interdisciplinary team salaries and so on. So there's quite a few of these now. There are something like, I think a couple of hundred now. What are the outcomes? Well, it's mixed, I think. Certainly a lot more people have now enrolled with a doctor than previously weren't enrolled with a family doctor in Ontario. I was staggered at that figure, 2.1 million. I'm not sure that's necessarily completely believable. And whether that's solely to do with the establishment of these family health teams is, I think, a moot point. GPs have done well out of it. Salaries are, on average, 25% higher than previously, but it costs. Something like 600 million Canadian dollars was spent on that particular family health team scheme in just a 2-year period, getting it set up and paying the additional incentive payments. And it's very complex operationally. There are 17 different kinds of organizational model and a whole series of concerns about conflicts of interest and so on. So, the picture is mixed. It's early days. Just on the other side of that diagram, we've got the ones where not only have pay for performance incentives been put in place, but also the model of remuneration has changed as well. And one familiar, quite widely studied example is the bundled payment schemes for diabetes patients in the Netherlands, and I've seen this in other countries as well, where insurers pay groups of providers, care groups they're called, a single payment to manage diabetes patients, and a whole set of incentives within that to deliver value for money. Again, the picture is mixed here. It certainly seems that costs have increased. in the most recent study that's been done on this at least. But like most of these studies, they're bedeviled with a very short, probably too short evaluation period. And if you do it at the early startup phase of a scheme, you're going to pick up a lot of expensive startup costs as well. The other problem that's frequently reported from some of these schemes, and including the Netherlands one, is that it's a black box, certainly from the payer's perspective. They pay the money, but they don't really know what's going on within the care group, in the case of the Netherlands. And a lot of concern amongst Dutch insurers about double billing and excessive claims being made. But again, in terms of clinical outcomes, there certainly seem to have been benefits there. So we have some evidence, we have some information on outcomes, clinical outcomes and economic outcomes, but as I say, it's very much a black box in most of these examples. We don't really know what works and why things work. I think, certainly so there's a plea for more research there and better research. What we can say, though, I think, is that there are two things that cut through a lot of these schemes, and there's some lessons, I think, about risk and how risk is managed, and there are some lessons about transaction costs and the complexity of the arrangements and the number of organisations involved in delivering healthcare and how you minimise transaction costs between them. And if I just take management of risk first, the general principle amongst these schemes or any sort of supply chain partnership type arrangement is that you need to allocate risk according to whoever's, how people are best able to manage it. If you try and offload all risk on, right down the supply chain to those who are right at the bottom and can't manage it properly, then you're going to get problems. You get relationships breaking down, and this is what the construction industry is bedeviled with. So risk management and risk allocation is critical, and getting it right is critical for these complex schemes to work. And if you do get it right, you can help people innovate. If people are prepared to take a risk and innovate with new ideas, so long as they're not being excessively exposed to that risk. So risk management is very important, but we know very little about how risk is managed in these different international examples of integrated care schemes. What we also don't know really is where the ultimate risk lies. Where is the backstop? If the whole thing fails, does it actually end up ultimately back with the Ministry of Health, the Department of Health, the government? And we also don't know really what the commercial risk premium is. If you have examples where you have a very long-term contract and a high contract value, usually there's some sort of premium on top of the regular risk to deal with that. And again, we don't know anything about that in these schemes. Just turning to the transaction costs and the contract. And the question here really is about where you draw the boundaries around the contract. And basically, the more people are involved, the more services are involved, the more you bundle it together into one contract, the more difficult it all becomes, and difficult to manage, difficult to align incentives, and difficult to actually write a contract that is complete and allows you to specify what performance you want to achieve. So the contract is important, but getting it right is very difficult. And again, I think this goes back to a point that was made earlier by Claire Gerarda, who said, "What does good look like?" Critically important, but how you write that in the contract is again, I think, something which we're only just beginning to learn. And the way I really look at this is in terms of a set of continua, really, where a sort of overlapping set of circles here, where the outer one here is the degree of, to what extent have you integrated services? How much have you bundled services together? And starting at the top of that clock, there's very little bundled service. It's essentially fragmented, and you go around and you get to fully bundled services. But generally speaking, the more you go towards an integrated model with lots of services bundled together, the more complex it becomes, the more public and possibly private and voluntary sector partners are involved, and the more difficult it becomes to write the contract. And if you just look at the examples I've talked about, and this is completely unscientific, if you start at the top with the traditional NHS, it may be all in the public sector, but it's essentially a fragmented model. And you go round till we've got our next speaker, the Alzira model, which is a population-wide public-private bundled partnership. There are various other models of integrated care within that spectrum, all with different degrees of complexity, both in terms of the organisational relationships and different degrees of complexity in terms of the contract and the financial models. So where North West London's going to sit on that, I think that's an interesting question. So finally, just a few things to take away and bear in mind for discussions later on. Risk-reward structures and incentivisation is critically important in integrated care, but what models work and when they work are unclear, I think. The contractability of what good looks like. How do we specify performance? How do we measure it, capture it, put it into an agreement between what may be a very complex alignment of partners? Again, is a bit of a unknown quantity, and I'd certainly be interested to hear more from Alzira about how they've done it. And then lastly, governance. What governance models are best able to provide a degree of public accountability and control over, again, what could be a very complex model with many parties and complex relationships. So, world tour of some of the evidence, and I hope I haven't rushed through that too much.
No, thank you, James. We need to move on. Let's go.